Is Red me now? Yes, it is. Hi, I'm Tony Marquardt. I'm president of the Austin Travis County EMS Association, and glad to be here today to introduce Dr. Escott. What I want to share with the commission is a bit of history. I've been one of the most outspoken critics, I think, of the former medical direction, having to do with due process and professionalism. And one of those things that I think is really relevant to our attrition rate and some of our matters related to clinical excellence has to do with people feeling like they're treated like professionals. And I think we can find a great balance between the integrity of a clinical event and also keep the accountability intact. That's something that Dr. Escott, who's only been with us for 6 weeks, and I have been able to accomplish in short order. There's a number of other things that medical direction will be involved in the future, and hopefully in the future items that come up on this commission, having to do with ESD response or having to do with our new concept of paramedic response unit. I'm confident that Dr. Escott is someone that's very good at this job and someone that will be a good fit for Austin. And so, without further delay, Dr. Escott.
Thank you, Tony. Welcome, Dr. Escott.
Thank you. Thank you for having me. It's been quite an interesting first 6 weeks, and I'm still trying to sort out the system and the challenges, what's working and what's not working. But I have been afforded the opportunity to meet with many stakeholders from the medical community, from the ESDs, and our own EMTs, paramedics, and firefighters to gain some insight into our Austin Travis County EMS system. I do have to say that I am quite impressed with what I've seen. And as I said during my interview process, this system is one of the crown jewels of EMS systems in the United States, and it's important that we understand that and appreciate that. Having said that, there are lots of opportunities for us to improve. I have come from EMS systems that have had challenges, and the challenges are not the challenges that Austin Travis County face are not unique to this system. But we do have an opportunity to work together, to create partnerships, and to move forward in a positive direction for the patients that we care for. As you all know, or maybe don't know, in 2011, the American Board of Medical Specialties recognized EMS as a subspecialty of medicine. And what this did for us is it creates a dynamic change in how we view EMS. Traditionally, EMS has been viewed as a third emergency service, but the act of making it a subspecialty of medicine transitions it into a medical profession, a physician-directed medical profession, and we have to start to change the way we think about our personnel because of that. We have physician extenders in other specialties, PAs, nurse practitioners, and when we view those physician extenders compared to ours in EMS, they don't look a lot alike. Our physician extenders have less education, they have less formal training, they get paid less, and they have a lot less oversight compared to our PA and nurse practitioner partners in the hospital. When we look at things like ratios for oversight regarding physician extenders, the hospital-based physician extenders have a 6-to-1 ratio of provider to physician. Right now in the state of Texas, there is no limit for how many providers an individual physician can look after. In this system right now, it's about 1,000 to 1. So we see some issues and some challenges associated with that. When we look at our challenges with our ESD partners, many of them are concerned because they don't feel like they're getting appropriate oversight from my office. And there's a reason for that, because we're not prepared to provide a tailor-made EMS service or credentialing process for each of the ESDs. And this is because we have a one-size-fits-all model for medical direction right now because of that challenge that we face with our FTEs in the Office of the Medical Director. So what we're trying to do is to sort out a system of how we can address those deficiencies, how we can mobilize our workforce to transition them from what has traditionally been a technician model of service to a clinician model of service, so that we can teach them, like we do our medical students, our PAs, how to practice medicine. It is a different dynamic than a technician-based focus. We simply can't boil down the practice of medicine to if-then protocols, because it's much more complicated than that. So the vision over the next 5 to 10 years is to sort out a plan that's going to allow us to transition at least a portion of our workforce to this clinician-based model of practice. Other countries have done this in the past. Australia, where I trained, the UK, parts of Europe, have transitioned the paramedic into a degree-based program. They've improved the formal education process and have developed the paramedics into more of a physician extender model with pay that's appropriate for a physician extender. The benefit that model has for us, at least for part of our workforce, is that it can help us address the deficiencies in healthcare in our community, particularly when we talk about our central health clients, our inner city clients that are underinsured or uninsured, as well as our rural communities that may face the same or similar challenges. So again, I'm only 6 weeks into the job, but our vision is to create a workforce that allows this upward progression of our clinical providers, our clinicians, to not only enhance their opportunities and enhance their clinical skills and knowledge, but also to address some of those deficiencies that we face in the healthcare system in the Austin-Travis County region. We'll obviously need significant input from this group, as well as other advisory groups, the Travis County Medical Society, as well as our FDEMS Advisory Committee. Because we do need a system that works well together. We do need to keep the system a system. We struggle in America to identify the healthcare industry as a system, because it's really silos of healthcare that happen. And to me, the Austin-Travis County system allows a model for us to transcend boundaries that may allow us to work smarter and in a more fiscally responsible manner. That's the overview of where I see things, and I'm happy to take questions from you.
All right, Mr. Levy.
I've been involved with the program since its inception in 1976. It was a jewel. It's starting to be more. There was a recent, in the last 2 years, professional journal article that refers to or describes Austin-Travis County EMS as a system at risk. And I think you are aware of that when you came in. This is a program that's difficult. Number two, you said that not all, how did you phrase it, not one fits all.
Correct.
Referring to the county ESDs.
Yes.
The reason we set it up as a unified system is to have one standard of one standard of care, regardless of political boundary. The purpose of a unified system is to ensure that regardless of where the patient was, whether it was Lake Travis or 7th and Congress, same standard of care. And it was important that one standard. The third thing is, and I think it's the most critical issue to me, we were promised by this commission, and the council was promised by the previous medical director, that we would not go to a one paramedic, one EMT model until we had a beta test in the central area of 40 stations to see how it worked. And then they unilaterally rolled it out. They told us, the previous Shamard told us, well, we decided unilaterally to roll it out. We are hiring 19-year-olds as EMTs. They barely have a driver's license, and they're driving multi-ton ambulances with licensed sirens. They have no clinical experience in the field. The paramedics have told me basically they're by themselves in the back of an ambulance. I'm an EMT. It's basically an advanced Boy Scout first aid course. And putting a paramedic two paramedics have two sets of eyes when they're trying to read a script, when they're trying to read an EKG script. And I think you realize it's not like being in a hospital ER where a patient is surrounded by docs and nurses, paraprofessional personnel. It's one paramedic. Now it was two paramedics backing each other up, and that was good. Now a paramedic says, "Hey, I'm by myself," and especially in complex situation where the patient's complex or you have a lot of patients in a multi-casual situation. I think this needs to be really looked at. I don't think we're going to put it on an agenda anytime soon, but I would like to ask you to come back and talk to us about your assessment of this. Having somebody who is an EMT on one of our ambulances significantly reduces the quality of what once was, as you call it, a jewel. That's it, Chair.
And Dr. Escott, if I could just follow up, I mean,
Sure.
the Medic 1, Medic 2 model doesn't really seem to mesh with your vision of having a more clinician-based as opposed to technician-based practice. So how do you see that evolving
Sure.
under your direction?
Well, one of the issues that we've had in the past, and I agree with Commissioner Levy, that my office has been resistant to the concept of having dual paramedic ambulances as well as paramedics in the ESDs because of the concern of skill dilution. And skill dilution is a concern. It's a concern for paramedics and EMTs and physicians as well. And we know this from evidence. You know, the more we do something, the better we get at doing that something. It's true for cardiac arrest. It's true for trauma. It's true for lots of different service lines. But what we have to appreciate is that there are opportunities to supplement those skills via other mechanisms. You know, if we have a credentialing requirement, for instance, of 20 intubations, well, that 20 intubations may happen in the field on real patients. If you're not able to achieve that, it may involve utilizing our hospital partners to allow for operating room time to intubate patients in the operating room, or it may be something we can bridge through high-fidelity simulation. So there is an opportunity to stay true to the science and address the skill dilution issue while maintaining a dual paramedic ambulance. So that's something that is on the agenda to look at so that we can identify what those credentialing numbers should be for initial credentialing as well as maintenance of credentialing. You know, as a physician, I don't get credentialed one time at a hospital and then I'm perpetually credentialed for the rest of my career there. I have to reapply for credentials every year. I have to meet certain benchmarks in order to be credentialed at certain skills. We should have a similar model for paramedics as well. So this is something that we're looking at. It's going to take some time to sort out how we address those credentialing needs and if it's a realistic model for us in the future. We also have to look at the demand and have to appreciate that we do want to also be fiscally responsible in how we spend the money regarding personnel deployment. We know about 75% of the cost for EMS systems is the people on the ambulances. So there may be ambulances that need dual paramedic system or dual paramedic trucks, and there may be ones that are not that busy that really may not benefit that much. Or there may be a system where we utilize paramedics on squads to provide that second set. Again, much of that are operational issues that is really under the auspices of Chief Rodriguez. But as the physician medical director, my role is to sort out how to address the plan that's in place from our various partners on the operational end and be able to supplement the needs regarding credentialing and maintenance of credentialing.
Chair, there's no such thing as a non-busy station. A station that doesn't catch a lot of calls in a day on average can catch a complex patient, and that's when you need two paramedics. It doesn't matter. Are you suggesting that you have a vision of returning to a two paramedic system?
Well, sir, I'd say that vision is up to this council, it's up to Chief Rodriguez, and it's up to city council regarding the funding. What
Why
I'm
would it
saying,
be up to Chief Rodriguez? You're the medical director. This is a
Well,
medical
I think
issue.
his point is
yeah.
well taken, that it is in some ways an operational decision, and in some ways it's a medical direction decision, right?
correct. My role as the medical director is to sort out how I'm going to maintain quality in whatever system we can afford. So it is a matter of what the city and the county is willing to afford.
We could afford a 2 paramedic system.
If we can afford a 2 paramedic system, then I can find ways to address that. But what we have to understand is that that requires increased medical oversight. If we look at this system as it is today, without any additional paramedics, if this system were in the state of New York, we would need to have 8 full-time physicians to provide oversight by law, because they have a 100-to-1 ratio for ALS providers and a 500-to-1 ratio for basic providers. Right now, it's about 1,000-to-1. So my response is, yes, we can do it. We can create medical direction systems that can address however the deployment model is that we decide on, but it's going to require increased funding to do that, and to do it responsibly. What we are trying to avoid with a fractured or a EMS system with lots of seams is we're trying to avoid differences in the standard of care and differences in the oversight for the various players within the EMS system. We know that it's the requirements by state law right now are very loose. So if an ESD, for instance, wants to put all paramedics on every fire truck, and have a medical director who is there one day a year, that's completely acceptable according to the state law. It doesn't practically provide very good oversight over what is a complex healthcare system. When I started as a paramedic in 1991, the job was a lot easier. We had a small bag of tricks. We had a 3-lead cardiac monitor. We didn't have pulse oximetry and end-tidal CO2 and all of the adjuncts we have now. Today, it's a much different system than it was in 1991 when I started. In 5 years from now, it's going to be a much different system then as well. We've got to appreciate that we need people who can be clinicians. Our paramedics are practicing medicine. Whether we call it that or not, they're practicing medicine today. They've been practicing medicine for the past 25 years. But we've tried to say, well, it's not practicing medicine because they're following a prescribed set of rules. Well, that doesn't work very well. And I'll tell you that in my experiences as a medical director and as an expert witness around the country in EMS malpractice cases, the technician model does not work. It places people at risk, and we have to sort out how we're going to mitigate that risk by creating a system of practitioners. And that's what I came here to do.
I'm sorry, you said the technician system puts patients at risk.
It does.
Thank you.
Who else? Mr. Scruggs? Yeah.
The clinician model you described sounds great. You also touched a little bit on emergency service districts, which we hear quite a bit about here. We know Travis County has several of them. Some of them are larger, some of them are smaller and getting smaller all the time. Some have expressed a desire to create their own ambulance EMS service. What type of challenges is that going to present to you to implement a clinician model countywide if these ESDs want to do their own thing, and how do you combat that?
Well, one of the systems that we're looking at doing is creating a menu type model for clinical credentialing, so that each of the ESDs, which are entitled to do their own thing, they have their own tax base, they can certainly break away if they want. But if we want to keep them together, we need to address the issues they have. And some of the issues are real. We've got issues like ESD1, which is in a remote part of this county. And what their needs are different from the needs of ESD12, which is very close to the city. So we have to have a system that addresses the needs and addresses what the citizens of their territory want to have and are willing to afford. That may be an advanced model, which is different from what we do in the city. It may be a basic model that doesn't want ALS providers. But it's really up to those ESDs to determine that. What we need the ESDs to understand is the same discussion that we just had about obtaining and maintaining ratios for oversight. If they want to have a paramedic on every fire engine, they've got to be willing to accept the fact that that's going to create increases in costs for oversight. If we look at the ILA as it exists today, it's not designed to address these concerns regarding ESDs that wish to enhance their response capabilities in regards to the increased need for oversight, and it should. The ILA should say that the ILA covers, in my opinion, basic life support, first response. If the ESD wants more than that, if they want ILS, if they want ALS, then we need to have a fee schedule for medical direction, for dispatch, and for all the other items that come with that, that they can be aware of and can make the informed decision about whether or not they want to proceed. But it shouldn't be up to the county, the whole county, to address those issues when it seems that there are only a few ESDs that really want to do something different.
Can you back up and give us a little background? So, of the emergency service districts, are you the medical director over all of them right now?
No.
Okay, so which ones have their own medical direction?
ESD 1 has their own medical director today, which is a gentleman from out of town, from Dallas-Fort Worth area. ESD 2 has given us notice that they intend to change. That's Pflugerville, with a Seton physician who is based in that area. And ESD 11 has indicated that they intend to leave the system and use Dr. Kempema from Starflight as their medical director. Now, some of them have indicated that they actually may be willing to come back to the system if the system can address their concerns. Some of the concerns are very legitimate. Some of the concerns we should be addressing. Some of the concerns we need to address for the whole system, including the city. And some are a bit more political in nature, and we need to sort out what our position is going to be in relation to those needs, particularly basic life support transport ambulances. So we know that ESD 1 and ESD 11 have both purchased an ambulance with the intention to do BLS transport. So again, there is a way that we may be able to address that and maintain them within the system, but that's something that is going to require careful discussion and consideration to determine if we can do that in a safe manner.
I think one of the concerns that when you describe how the different ESDs want to do different things, the fear that we could have this patchwork of medical direction out there, and we've seen the maps how the ESDs are all throughout the county, bits and pieces. What about those people that live in the border or between the county authority and the ESD authority? How do they know that they could be getting the same quality, for example, life support system care on a call if we end up having this patchwork?
Well, again, that's the challenge of having a system which is fractured. That's the need of maintaining the system together. That's the need of having common dispatch and common medical direction so that we can sort out those issues without significant challenge. Inevitably, what we see when systems break apart like this is that there ends up being a person dying on one side of the street, and on the other side of the street is the ambulance that is not dispatched to that emergency because it's not in their territory. We want to try to avoid that type of situation at all costs because it does a disservice to our community that may not know any better regarding the actual implications of having the system which is fractured. So that's, we have to also appreciate that the ESDs can do what they want. They're ruled by a board of commissioners. They have a tax base. They are entitled to do their own thing if they choose to do that. I've worked in 2 other systems that combine, that have a common EMS service with multiple ESDs. The last one in Montgomery County, when I started, had 18 ESDs and 1 EMS service that covered the whole territory. The difference with both of those other services is that there was a common EMS tax base, a common overlying, in one circumstance, an EMS ESD that covered the whole territory, which kept the system together. In the other circumstance, a hospital district that ran EMS service, but had a common tax base across all the ESDs, which provide a powerful incentive to stay together as a system. We don't have that here.
Do you think, from what I'm hearing, do you think that it would require changes perhaps in state law or state regulatory law in order to create a system where there are more safeguards?
It may. Again, the essential issue is that, number one, there's no set ratio for oversight. So what we see happening over and over again in ESDs is, they decide they want to have paramedics or, advanced life support providers. There's nothing that forces them to have a physician providing oversight for any significant amount of time. In the last system that I was a part of, they wanted to reduce my time to 2 days a week for a system that has 1,100 providers and collects $17 million a year in revenue from EMS service. And they can do that. There is no requirement under state law for how much medical direction you need. Because there's not, it makes it very easy for ESDs to decide what their own formula is and find a doctor who's willing to sign off on that system, even though they're not providing appropriate oversight of it. And we're seeing this concern from CMS as well, particularly when it comes to private ambulances that, as you may know, in the state of Texas have billed hundreds of millions of dollars in unnecessary transports over the past decade because EMS services have had a rubber stamp medical director who is willing to sign off on things and not really provide significant oversight. So I do see that there is a need for legislative change. We see movement happening regarding set ratios for physician oversight in the ratios that are similar to what the state of New York is providing, so that you have that safeguard. You do run it like a healthcare system, which is what it is. We care for 120,000 or so people a year. If this were an ER, it'd be one of the top 2 in the state of Texas. It's a very busy healthcare system. We've got to treat it like that, and we have to have mechanisms to prevent people that want to hang out a shingle as EMS and that are doing it in an irresponsible manner. We also have to appreciate that there is financial incentive for them to do that. If we look at the ESDs, for instance, that run a fire service, some of them have limited tax base, and they may see EMS as an opportunity to create revenue for their ESD and for their fire department. In some circumstances, they've outright said that. The primary motivator should not be a source of revenue. It should be about the provision of health care. And to me, pulling away from a system like Austin Travis County EMS without significant argument for doing so and significant public comment is probably an irresponsible thing to do.
One quick follow-up, and then we'll come to Dr. Rossmo. You mentioned that the interlocal agreement might need to be amended. That sounds like a political issue but could that ever be a medical issue, like a clinician issue for you?
I'm sorry, I don't understand.
You mentioned that the interlocal might need to be amended with regards to, oversight. You mentioned that one ESD is overseen by a doctor who's not even in town. So what I'm asking you is, could amendments to the interlocal agreement be important from a medical direction viewpoint as opposed to
Sure.
just political interests?
Yeah, absolutely. I think the interlocal should certainly address what type of system is covered by the interlocal and what is not. The interlocal should describe appropriate ratios for physician and medical direction, as well as FTEs associated with that quality mission, so that we can better define what the expectations are. If we don't do that and we continue to allow what's happening to continue, we are going to end up with a system that is vastly different between jurisdictions, and it's hard to justify that to our taxpayers and to folks who may not know any better regarding the consumption of healthcare for their particular ESD.
Dr. Rossman?
Chair, for your information, the county pays 1/3 of the operating cost of Austin Travis County EMS. The money has always been there. What has happened is that the system ran off the ESDs in terms of medical control. They felt like they were being treated as small children. Just, with all the interlocals the city and the county have had, the city has never played well on the same sandbox as the county.
Dr. Escott, there's been some discussion, and it might even be a pending future agenda item for this commission, about the idea of merging AFD and EMS services. What are your thoughts on that? I realize, early days.
Sure.
But just anything you might want to share with us.
Yeah, I've never seen that done well. That doesn't mean it can't be done well, but having knowledge of systems that are combined systems, and also providing expert witness testimony in some of those systems, it is hard to have a dual mission and maintain focus primarily on the EMS mission. If we look at the city of Houston, for instance, if we look at Washington, D.C., if we look at the city of Chicago, what happens is when the merger happens, EMS becomes subservient to fire, and it's not just an operational issue, it's a cultural issue. And we have to be cognizant of the fact that primarily what both systems do is EMS right now. We've got about, and the chief can give more specifics on the numbers, but we've got between 75 and 80%, I believe, of the fire department effort, both city and county, which is EMS. So, to me, I would be hard pressed to find arguments to combine the two. I think what we need to focus on, however, is identifying which resource needs to go to which emergency. Right now, we have a lot of calls that both fire department and EMS are going to that don't need a fire department. They're not a time-dependent emergency. It is not a critical patient, and having a fire apparatus arrive 2 minutes sooner may not make a significant difference. We have some that clearly need both because it's a critical nature, or because the response interval for the ambulance is going to be extended. And we have some circumstances where we may find that the incidence of transport from a various call type is extremely low, where we may just need a fire truck and not an ambulance. I think if we look at opportunities for triaging these calls better and sending the right resource to the right emergency, we'll see that we can spend our tax dollars wiser by sending the right piece of equipment to the right type of call. Again, it's I've seen comments from fire chiefs that regret merging of the systems. We see efforts to try to split the systems now. I would struggle to find a reason to advocate for that at this stage. Again, I've only been here 6 weeks, and that position may change, but I think it appears that both systems are functioning reasonably well right now, being separate.
So your predecessor spoke to our commission and was asked about a recent suicide of a paramedic and some troubling responses to a survey about morale within EMS, and then also just a poor attrition rate within the agency. And he was pretty adamant that was not a medical director issue, that he was an independent, he oversaw an independent office, and that didn't have to do with the clinical side of things. I wondered if you could give us your perspective on that.
Well, I think there is, when you have a big system, it lends itself to a disciplinary model of oversight. And it's hard for me to assess what happened before I got here. But I can tell you that my philosophy is to treat our medics with respect and understand that it is a difficult job, and that when people put on the uniform and sign into work every day, their intention is to do the best they can for the patients they care for. And it's not different from the way I see my role as a teaching physician at the medical school. We have to understand that they're not going to be perfect, that they are going to make mistakes. Some of those mistakes may be significant mistakes, but our job, my job, is to make sure that they learn from that mistake, that the system learns from that mistake, so that we can avoid those mistakes in the future. This is consistent with how we train physicians, interns, residents. This is consistent with how we train physician extenders. So from my viewpoint, when we bring medics in for clinical issues, it's focused on development. It's focused on how to fix that issue, how to mitigate that deficiency, so that we can make a better and stronger paramedic. You'll find that, at least in my opinion, folks who realize that they're fallible are much better clinicians than those who think that they're perfect, because they have a healthy respect for the consequence of error, and they tend to be more careful. So I am quite forgiving when it comes to those types of issues. We have to do it in a responsible way. We have to do it to ensure the safety of the system, but we can do that in a respectful way, so that we can both enhance and develop our paramedics while providing that safety net for the community. I think that the morale is not just an issue of medical direction and operational issues, but it's also one of a sense of a bit of a cognitive disagreement with what the medics' expectations are. As Commissioner Levy said, this system used to be a system where people would have to wait in line for years and years for an opportunity to get into Austin Travis County. I remember, because I was a paramedic at that time in the late 1990s, when everybody wanted to go to Austin, but they had to have 3 or 5 years of experience in order to even get in the door. What we found now is, and this is my perception after 6 weeks, but we have folks who think that that's still the system, and who want to be clinically excellent and want to be cutting edge and developers of research in the field. But right now we're stuck in a model of a one-size-fits-all model that is more common in large cities, but is not necessarily the type of atmosphere that the paramedics that we recruit are looking for. So again, what we're trying to do is create an atmosphere that if there are medics who want to be more astute clinicians and want to develop their skills and want to progress towards that paramedic practitioner model, that we have opportunities for them to do that within the system so they can have the satisfaction and recognition of doing a good job and being committed to professionalism that is going to come with advanced abilities to care for patients. So I think we'll be able to address that on multiple levels, and I think that some of the initiatives that Chief Rodriguez has initiated with the work on fatigue is going to help combat that that issue that has plagued the system for the past several years.
Well, thank you so much for coming,
You bet.
and we look forward to hearing from you about how it's going.
Thank you.